Hello everyone, welcome back to week 5 of COVID-19 Health Systems and Pandemics. My name is Dr. Clem. I'm an adjunct professor of data science at Geisinger Commonwealth School of Medicine. Dr. Solzinski started the course by introducing you to SARS-CoV-2, its virology, testing, and vaccine response. Next, over the last 2 weeks, Dr. Tarifdar described the basics of infectious disease transmission and modeled droplet transmission. He ended by discussing the role of mathematical modeling in infection control. So how have previous pandemics been mitigated? How has this informed the COVID-19 pandemic response? As a Bucks County, Pennsylvania Medical Reserve Corps unit leader, I've been actively involved in preparing for pandemics for the last several years. Since March, I've been part of our Epidemic Investigations Unit at the Bucks County Department of Health, working on the local level response in a variety of capacities. So I'm going to draw from these experiences as I review mitigation via quarantine and other strategies. So let's get started. By the end of this lecture, you should be able to give examples of previous pandemics. You should be able to compare key approaches used during these previous pandemics and then describe some contemporary strategies currently being employed. Let's take a quick walk down the halls of pandemic history. We'll examine the response to major disease events up till the COVID-19 pandemic. Before you move to the next slide, assess your knowledge. Stop the podcast. See if you can list 3 past pandemics on your own and the associated infectious agent. Can you list any of the mitigation strategies that were used during any of those? We are going to use this timeline by the Washington Post as the framework for our discussion. It highlights pandemics that had a significant impact on history, which was often represented by the highest mortality, but not always. The timeline starts from antiquity on the left to the modern era on the right. Note that the modern era period, from 1900 to 2020, is expanded in the center of the graphic. The animation on the right is a good way to quickly gauge the differing levels of severity. I do want you to note that this graphic refers to some pandemics that were named according to the place of origin. WHO's best practices, created in 2015, address how diseases are named. The best practices discourage geographic names, people, animal species, cultural references, and terms that incite undue fear, such as the word plague. These types of names could have lingering negative effects. So, for instance, the name swine flu led to one country to slaughter all its pigs, even though the virus was not spread through pigs. Lyme disease had unintended negative impacts by stigmatizing the community of Lyme, Connecticut, so the name Lyme disease, for instance, doesn't adhere to WHO's best practices. On average, 3 pandemics per century have been documented since the 16th century, occurring at intervals of roughly 10 to 50 years. As you can see on the graphic, for instance, in the 20th century, pandemics occurred in 1918, 1957, and 1968. Otherwise, this graphic was done earlier this year, when the number of deaths attributed to COVID was just over 70,000. At this point, how many deaths globally have been attributed to this disease? As of October 2020, it was estimated to be over 1.1 million, which puts it in the realm of pandemics like the flu outbreaks in the 1950s and 60s. So let's take a brief look at some of these individually. We'll focus on methods of mitigation for each in order to compare and contrast mitigation strategies. Let's start with the Antoine Plague, which is significant as many historians trace it to the fall of the Roman Empire. Over 2,000 may have died daily. Symptoms recorded by the Greek physician Galen, who by the way is known for laying the groundwork for a lifestyle approach to medicine, included skin sores, high fever, diarrhea, and sore throats. These strongly suggest it may have been smallpox or maybe measles. Romans responded by calling on the gods. Delegations were sent to Apollo, asking for the god's advice about how to survive. Archaeologists working in this region still find amulets and little stones carved by people desperately trying to ward off disease. Due to its virulence and high case fatality rate, which is about 50%, Franks noted in his book, Epidemics and Society, that bubonic plague is a key reference point for any discussion of infectious diseases. Caused by the bacterium Yersinia pestis, the name comes from the hard bubo in the armpit, groin, or neck caused by inflammation and swelling of a lymph node. We will therefore talk about 3 key plague events and then the overall response to plague before moving on in the timeline. In around 541 CE, 13 to 51% of the world's population fell victim to the plague of Justinian, which was named after the Byzantine emperor who was in power when it hit. There were about 18 successive waves over a period of 200 years, until it mysteriously disappeared in the mid-700s. Some historians speculate that this was the world's first episode of bubonic plague. The plague of Justinian may have in fact ushered in the period of migration, also known as the early Middle Ages, which used to be known as the Dark Ages. J.N. Hayes, the author of Epidemics and Pandemics, Their Impact on Human History, notes that people during the plague of Justinian believed that God had scourged regions in their atmospheres, and to counter this they tried to clear the air. There was deliberate smashing of pots, people making a clamor, perhaps done somehow to disturb and clear the atmosphere. There was also evidence of extraordinary state-organized sacrifices. On the right is a medieval painting depicting priests giving last rites to a victim during the plague of Justinian. Like the plague of Justinian, the Black Death was caused by the bubonic plague and likely earned its name from a symptom, lymph nodes that became blackened and swollen after bacteria entered through the skin. Up to 200 million may have died. The majority of the population of Western Europe was on the edge of poverty due to deepening economic depression, likely leaving them immunosuppressed and vulnerable to disease. The devastation was so widespread that this plague inspired the first and most draconian form of public health policy to protect populations and enforce the isolation of the sick. During the Black Death, there were no facilities, administrative, religious, or medical in place to deal with the tidal wave of the disease. People often died alone and without the attention of clergy. They were often denied funeral rites and proper burial. Many doctors perished during the outbreaks or fled plague-threatened cities. An illustration shows infected clothing being burned in medieval Europe circa 1340. One of the final epidemics of the Black Death was the Great Plague of London in 1665. It's likely that the death toll was lower than the Black Death as it was localized to the British Isles. There's also evidence that people tried to make sense of the devastation by scapegoating outsiders. In England, for instance, at that time, there were violent attacks on Flemish merchants and weavers. The Third Bubonic Plague in 1885 also erupted in the wake of social unrest and warfare. Unlike its predecessors, it followed international fault lines of inequality, poverty, and neglect, affecting cities like Hong Kong, Honolulu, Sydney, Buenos Aires, Cape Town, Mumbai, then called Bombay, and San Francisco. Some estimates suggest that the death toll was actually closer to 20 million. This plague had 2 key impacts. 1. It left a stable reservoir of infection in rodents in the Americas, including the U.S. Southwest, which still persists today. 2. Rats were known to be a sign of impending plague since the Middle Ages. However, it's not until the Third Plague that the etiology, the manner of causation of the disease, became more clear. The connection between fleas and rats and human disease then led to public health policies focused on targeting rats and fleas as part of disease mitigation strategies. In the photo, for instance, we see the Liverpool Port Sanitary Authority, the rat catchers from that group, dipping rats in buckets of petrol to kill fleas for plague control. By some accounts, this is actually the first time that an epidemic or outbreak was photographed. Snowden categorized the community responses to these plagues into several themes. Spontaneous reactions included the first and most universal reaction, which was to flee. Medical doctrine at the time explained that there was a mass imbalance of humors in corrupted air, so fire, smoke, and aromatic agents like pine and sulfur were part of the purification strategies. Bloodletting was also done as part of this. Streets were washed to cleanse for religious reasons due to the symbolic role of water in purification. Individuals would carry around a bottle of vinegar or herbs to smell. The beak on the mask of a plague doctor, shown on the left, would typically be filled with aromatic herbs to protect the wearer. The staff could then be used to prod a patient from afar looking for buboes. They also carried talismans, like rubies. There were violent forms of cleansing at the population level, however. Communities would cast out those that they considered to be morally responsible for disease by practicing sins such as prostitution. To them, the only way a plague could be halted was to find and punish such culprits. Ethnic cleansing involved foreigners being run out of town or being burned at the stake. Some communities also banned public assemblies. The most harrowing and likely famous plague testimony comes from Giovanni Boccaccio in the Decameron, based on an experience from Florence, Italy in 1348. This pestilence was so powerful it was transmitted to the healthy by contact with the sick. The way of fire close to dry or oily things will set them aflame. They shut themselves up in those houses where there were no sick people. They went around carrying in their hands flowers or sweet-smelling herbs or various kinds of spices. They would often put these things to their noses, believing that such smells were a wonderful means of purifying the brain. Medieval Italian writer Tommaso del Garbo, who offered practical advice to physicians entering the homes of the infected, said, "On entering their houses, one should open the windows so that the air is renewed, and wash their hands with vinegar and rose water, and also their faces, especially around their mouth and nostrils. It's also a good idea, before entering the room, to place in your mouth several cloves and eat 2 slices of bread soaked in the best wine, and then drink the rest of the wine. Then, when leaving the room, you should douse yourself and your pulses with a sponge soaked in vinegar. Take care not to stay too close to the patient." Piety and plague cults also sprung up to appease an angry god through penance and self-abasement. For instance, a group known as the Flagellants, shown on the top right in an 1867 French painting, chanted penitential verses while whipping their backs with knotted leather tongues tipped with iron until blood flowed. The first institutionalized forms of public health appeared in Venice in response to the Second Plague. Authorities from the Venetian Office of Health relied on 3 major strategies to mitigate the plague: quarantine, lazarettos, and sanitary cordons. A lazaretto is an offshore quarantine station. After ships were docked, often on outlying islands, they were scrubbed and fumigated. The crew and passengers were taken ashore by guards to be isolated in the lazaretto, and their possessions fumigated and aired. Arrivals were confined for 40 days. 40 in Italian is 40, from which the word quarantine has been derived, a duration likely derived from biblical references. This was likely effective as it exceeded the incubation period of the plague and was a sufficient period to kill any infected fleas. The images on the top show apparatus that were used for disinfection of clothing, letters, and papers in the lazaretto for plague prevention. Therapeutic approaches such as bloodletting, as we described earlier, also known as venesection, emetics and purgatives were also employed in the lazarettos, likely to no avail as the case fatality rate between the treated and untreated seems to be similar. Inland, vigilante parties often formed to patrol the perimeter of cities and towns in plague-ridden areas. These troops were known as sanitary cordons, and they repelled anyone who approached until quarantine could demonstrate that they were medically safe. The bottom image shows the sanitary cordon formed in response to the cholera epidemic in Egypt. In the Ottoman Empire, which encompassed much of the Middle East, North Africa, and Eastern Europe, sanitary intelligence officers observed and questioned travelers. Let's continue our look at history's worst pandemics. In what has been called the Columbian Exchange, when European explorers got to the Americas, they brought guns, horses, and unfortunately diseases like measles and smallpox. There is no record of smallpox in the Americas. There is also no clear consensus on the size of the native population in the Americas in 1491. Some estimates are as high as 110 million. As they were immunologically naive to these diseases, some regions lost their entire populations. Some historians believe that almost 95% of the American Indian population of the Americas succumbed to smallpox. On the island of Hispaniola, now divided between Haiti and Dominican Republic, the population went from about 1 million to 15,000 due to smallpox. Snowden notes that whereas some of the deaths were not intended, there is at least one documented instance where a British officer proposed intentional genocide by weaponizing smallpox through giving blankets used by colonists infected with smallpox to American Indians. The image shows Aztec smallpox victims. One of the first methods for eventually controlling the spread of smallpox was the use of variolation. Named after the virus that causes smallpox, the variola virus, variolation is the process by which the material from smallpox sores, known as pustules, was given to people who had never had smallpox. This was done by scratching the material into the arm or inhaling it through the nose. Benjamin Franklin, who lost a son to this condition, was an early advocate of the treatment. Variolation was the sole method of protection against smallpox, other than quarantine, until Edward Jenner's discovery of the inoculating abilities of cowpox against the smallpox virus in 1796. This was the world's first vaccine. During the 1918 pandemic, the deadliest pandemic of the 20th century, it is estimated that about 500 million people, or one-third of the world's population, became infected with an H1N1 virus. You'll see this called the Spanish flu in communications from that time, but recall that name doesn't adhere to WHO's best practices for naming diseases. The number of deaths was estimated to be at least 50 million worldwide, with about 675,000 occurring in the United States. The high mortality in healthy people, including those in the 20 to 40-year age group, was a unique feature of this pandemic, and researchers are still not clear on what made it so devastating. A strong body of evidence implicates other pathogens in the extreme loss of life of the pandemic. Most of the human victims were co-infected with bacteria such as Streptococcus or Staphylococcus. The pandemic lowered the average life expectancy in the United States by more than 12 years, leaving countless widows and orphans. By the 1900s, the germ theory of disease and the ensuing sanitary movement directed public health towards more targeted microbial control. During the 1918 pandemic, a series of non-pharmaceutical public health interventions, known as NPIs, were implemented. NPIs are actions, apart from getting vaccinated and taking medicine, that people and communities can take to help slow the spread of illnesses. With no vaccine to protect against influenza infection and no antibiotics to treat secondary bacterial infections, control efforts worldwide were limited to NPIs such as isolation, quarantine, good personal hygiene, the use of disinfectants, making, and limitations of public gatherings. Marco et al. In 2007 evaluated the use of NPIs during this particular pandemic. They grouped them into three major categories: school closures, cancellation of public gatherings, and isolation and quarantine. They examined 43 cities that adopted one of these NPIs over a 24 pandemic period. School closure and public gathering bans activated concurrently represented the most common combination implemented and was significantly associated with reductions in the weekly excess death rate. The cities that implemented non-pharmaceutical interventions earlier had greater delays in reaching peak mortality, lower peak mortality rates, and lower total mortality. There was also a statistically significant association between increased duration of non-pharmaceutical interventions and a reduced total mortality burden. During the 1918 pandemic, there was a rise in printed communication. As the death toll rose, public health recommendations were distributed in pamphlets, republished in newspapers and journals, and displayed as placards in train stations, store windows, and movie theaters. Posters reading "Spit spreads death" were hung all over town. Boy Scouts gave people coughing in public cards that read, "Stop, you're in violation of the sanitary code." The Public Health Service, newly named in 1912, more on this next week, instructed 6 citizens to remain home to avoid infecting others and to maintain a proper proportion of work, play, and rest, to wear warm clothes, spend time in fresh air, avoid crowds, and eat sufficient, wholesome, and properly selected food. They also issued a warning that patients only take medicine prescribed by a doctor, as it was foolish to follow druggists' advice to try the so-called safe, sure, and harmless remedies advertised by patent medicine manufacturers. The close connection between the First World War and influenza was evident when newspapers illustrated Uncle Sam's advice on flu, with a graphic showing a sick man standing in front of a crowd that included civilians and soldiers. This is shown on the top left. During this time, they erected emergency hospitals and had arguments about the usefulness of masks and canceling school and social gatherings. On September 28 that year, the city of Philadelphia went forward with a Liberty Loan parade attended by tens of thousands of Philadelphians, spreading the disease like wildfire. In just 10 days, over 1,000 Philadelphians were dead, with another 200,000 sick. Only then did the city close salons and theaters. By March 1919, over 15,000 citizens of Philadelphia had lost their lives. In contrast to today, the 1918 publication cycle was slow, however, and more distributed. Some newspapers even delayed publication for as much as a month. People gargled salt water, wore camphor sachets like the kids in the bottom images. The advice that nurses and physicians wear gauze masks was eventually discarded as medically ineffective. By the time H2N2 hit during the 1957 flu pandemic, antibiotics and vaccines for diseases such as yellow fever and polio had been developed. Maurice Hillman at Walter Reed Army Medical Center requested samples of the new virus to be shipped to U.S. drug makers so that they could get a vaccine ready. The vaccine that was eventually developed was judged to be 45 to 60% effective. Though 70,000 people in the United States ultimately died, the Philadelphia Vaccine History Project noted that some predicted that the U.S. death toll would have reached 1 million without the vaccine. In the image, a nurse gets the first flu vaccine shot to be administered in New York on August 16, 1957. So how did these past experiences affect our strategy to deal with pandemics? There have been many books and papers written about the 1918 flu pandemic, and one of the main themes is how quickly it was forgotten and how fast it disappeared from political discourse. Frank Snowden notes that the world has alternated between feast and famine concerning epidemic infectious disease, with a recurring pattern of social amnesia prevailing. Each microbial challenge has been followed by a period of frenetic activity, and then concluding with a lapse into forgetfulness. One of the reasons for this he attributes to microbial fixity, that the prevalent thinking during the 20th century was that we would face known threats, such as plague, malaria, and yellow fever, and there was no need for regulation regarding unknown microbes. There was also a perception that with vaccines and antibiotics, infectious diseases would no longer be a threat. This changed with the advent of HIV/AIDS in the 1980s. We're not going to discuss the ongoing HIV/AIDS pandemic simply due to the enormity and complexity of the pandemic and our limited time together. In 1996, a White House fact sheet on emerging infectious diseases noted that the national and international system of infectious disease surveillance, prevention, and response is inadequate to protect the health of U.S. citizens. It added that contributing factors such as climate change and ecosystem disturbance showed no sign of abatement. One key action was to establish a standing task force of the National Science and Technology Council, the NSTC, to provide strategic planning and further coordination on issues of emerging infectious diseases. Policy goals included strengthening and building of domestic and global infectious disease surveillance and response systems, improving diagnostics, treatment, and prevention, and promoting public awareness. Like the U.S., the United Nations announced that it also regarded infectious disease as a threat to national security. On the global front, the World Health Organization, who is responsible for coordinating the international response to health emergencies, also established the Global Outbreak Alert and Response Network, GOARN. Over 500 experts from over 16 countries collaborated to increase global capacity to respond to rapidly emerging epidemic emergencies. When severe acute respiratory syndrome SARS arrived in 2002, it was the first severe and readily transmissible disease to emerge in the 21st century. By the end of the outbreak, it had affected over 29 countries across 5 continents. There was no treatment nor a diagnostic test. WHO coordinated the international investigation with the assistance of the newly formed GOARN and worked with health authorities in affected countries to provide epidemiological, clinical, and logistical support and to bring the outbreak under control. Aided by the internet and real-time global collaboration, it was identified in 2 weeks. The use of now familiar NPIs like increased hygiene, barrier protection such as masks, quarantine, border controls, case tracking, traveler surveillance, and cancellation of mass gatherings proved to be effective in containing the global threat in just over 3 months. Evidence of supershedders, or known as superspreaders, who are individuals who disproportionately affect a large number of contacts, also emerged during this time. In particular, SARS exposed the absence of surge capacity in hospitals. Paul Colford, the chief of family medicine at the time at Scarborough Hospital in Toronto, wrote an impassioned plea for better pandemic preparedness in the Lancet. SARS must change us forever, he said. Every hospital, every emergency room, every nursing home in every community in the world should be ready for SARS, putting in place a precise plan of response that can be activated the very moment there is a suspected case. But before that, and for that to happen, every nation's government should sit down and join forces in a partnership of world health. After SARS, WHO produced a global influenza preparedness plan in 2005. This laid out a country-by-country strategy for addressing the possibility of the prolonged existence of an influenza virus of pandemic potential. It redefined pandemic phases that had been outlined in 1999, before SARS. The new phases were the interpandemic period, the time in between pandemics, when surveillance was most important; the pandemic alert period, during which human infection would be occurring but still on a localized basis; and the pandemic period, when there would be sustained transmission in the general population. One of the major changes from the pre-SARS version was addressing the influence of non-human animals on human health. Another key difference was placing greater attention on the earlier stages, such as the interpandemic period, when rapid intervention might contain or delay the spread of the new virus. Goals and actions were then outlined in accordance with each stage. Certain objectives and actions were specific to influenza, while others addressed preparedness for and response to many health emergencies that affect large numbers of people. At this time, WHO also revived international health regulations to include emerging disease threats such as notifiable events and devised its rapid response capabilities. This plan also outlined detailed recommendations for NPIs on a national level. This includes social distancing measures like closure of schools and workplaces, measures to decrease the interval between when an individual develops symptoms and becomes isolated, and measures such as masking to reduce risk and tracing and follow-up of contacts. Also included in the plan were strategies to communicate with the public. Here NPIs became known as Community Mitigation Strategies. According to the CDC, data has shown that NPIs are amongst the best ways of controlling pandemic flu when vaccines are not yet available. Measures at the international level were also outlined, such as health alerts, recommendations of deferral of non-essential travel to affected areas, entry and exit screening, and specific guidance for countries with porous borders, and for modes of transportation such as aircraft. Also in 2005 in the US, a national strategy for pandemic influenza was generated. Some accounts attribute this plan to the president at the time, George W. Bush, who read an account of the history of the 1918 pandemic that year. This plan laid the structure for similar strategies at the state level and in the private sector, and identified a comprehensive national strategy with 3 pillars. To enhance the pillar of preparedness and communication, pandemic response plans were developed, established, and exercised. Medical, veterinary, and scientific surge capacity was expanded, and non-health sectors were engaged. Guidance was provided to individuals and entities unaccustomed to responding to health crises. Key aspects of preparedness identified were accelerating the development of medical countermeasures such as vaccines and antivirals, producing and stockpiling of these materials and associated medical supplies, which were referred to as the strategic national stockpile, as well as establishing distribution plans for vaccines and antivirals. As part of the second pillar, surveillance and detection, a push was made to advance mechanisms that optimize the rapid reporting of outbreaks, such as real-time clinical surveillance, using active and passive surveillance to limit spread, and enhancing screening and monitoring of non-human animals that could harbor viruses with pandemic potential. Lastly, as part of the response and containment pillar, guidelines were developed to contain outbreaks, which we will get into more next week, and leveraging the medical and public health surge capacity to meet local shortfalls. Sustaining essential services and the economy and building of local capacity to support this infrastructure was also mentioned. After this strategy was developed and implemented, there was a lull on both the national and international levels as funding was slashed. Agencies responsible for coordinating the response at the international, federal, and state levels was unfortunately disbanded. Ebola virus disease, EVD, is a rare but severe, often fatal illness in humans. The average EVD case fatality rate is about 50%. At the time, the 2014-16 outbreak in West Africa was the largest Ebola outbreak since the virus was first discovered in 1976. It exposed just how unprepared the world was to face the challenge of epidemic disease. Ebola circulated silently for months because there was no means of surveillance when it spread from Guinea and then moved across land borders to Sierra Leone and Liberia. Some experts have since said that it was on the brink of being transmitted across the African continent and spreading uncontrollably. WHO specifies that effective Ebola outbreak control relies on applying a package of interventions, namely case management, infection prevention and control, surveillance and contact tracing, a good laboratory service, safe and dignified burials, which is unique to Ebola due to cultural practices in affected regions, and social mobilization. Community engagement is particularly key to successfully controlling outbreaks as well as reducing the risk of wildlife to human transmission. Ebola is one of the zoonotic diseases that has demonstrated how changing land use practices have a direct impact on animal and eventually human health. It was likely that there was a spillover of Ebola from bats to humans. Over the last decade, One Health has been gaining recognition in the United States and globally as an effective way to address issues at the human-animal-environment interface. One Health is an approach that recognizes that the health of people is closely connected to the health of animals and our shared environment. This approach builds collaboration across disciplines and sectors to focus limited resources on preventing, detecting, and responding to those zoonotic diseases of concern. The Office of One Health at the CDC was formed just a few years before this outbreak occurred. Experts there are working globally to implement a One Health zoonotic disease prioritization process. Some consider that SARS and the Ebola outbreak just a decade later were the dress rehearsals for COVID-19. On the heels of the 2014 Ebola epidemic, experts at the CDC reviewed almost 200 research articles published between 1990 and 2016 on the effectiveness of NPIs both when used alone and in combination, including new modeling studies. They updated guidelines from 2007 and made specific recommendations on the use of personal, community, and environmental NPIs. Recall, NPIs here are called community mitigation strategies. These are shown in the table. This includes voluntary home isolation of ill persons, so staying home when ill, and respiratory etiquette, hand hygiene, and routine environmental surface cleaning measures on both a personal and community level, all year round, but especially during annual influenza seasons and during a pandemic. Note that they made pandemic-specific recommendations that reflected increased reliance on technology to reduce disruption, such as distance learning and telecommuting for workplaces. Are these starting to sound familiar? Recall, this was only 3 years ago. The research team also evaluated the 2009 H1N1 pandemic response, which we didn't review specifically, and highlighted lessons learned from this experience. A key point was the importance of NPIs while the vaccine was being prepared. This took about 8 months to get to vulnerable populations. They noted that pre-pandemic planning must be broad and flexible to accommodate unpredictable emergence, severity, vulnerability, and spread, and that rapidly changing guidance can create confusion and difficulties during implementation. They also realized the need for new and updated pandemic assessment and planning tools, so they provided several, including an influenza risk assessment tool, a pandemic severity assessment framework, and a set of pre-pandemic planning scenarios. Note that the figure indicates a level of severity based on historical experiences. I've included a link for you to check these tools out on your own. To facilitate implementation of the updated guidelines and to assist states and localities with pre-pandemic planning and decision-making, they provided pre-pandemic NPI planning guides for different community settings that would then be available online. A big change from previous planning strategies was that they added a section on community engagement to highlight that timely and effective use of NPIs depends on community acceptance and active participation. And so this is where the Medical Reserve Corps comes in, and this is about the time that I joined our local unit. The Medical Reserve Corps is a national network of medical and non-medical volunteers under the Department of Health and Human Services, which itself is under the Office of the Assistant Secretary for Preparedness and Response. MRC units are organized by community, so for instance, I'm a member of the Bucks County, Pennsylvania unit that is active both during emergencies and throughout the year, when we do activities like preparedness trainings and drills. Yes, so we've been practicing how we would respond to a pandemic the last few years, emergency shelter staffing, and FEMA training. They also discuss the ethical aspects of some of these decisions. You will learn more about this aspect in week 9 of this course. Also spurred by the Ebola emergency in West Africa, in 2018, WHO appointed a commission to assess global preparedness, aptly named the Global Preparedness Monitoring Board, the GPMB. The goals of the board were to assess the world's capabilities to protect itself from health emergencies, to identify critical gaps in preparedness across multiple perspectives, and to advocate for preparedness activities with national and international leaders and decision makers. So again, we're seeing an emphasis on preparedness. The GPMB published its first annual report in September 2019 titled A World at Risk. This report provided a snapshot of the world's ability to prevent and contain a serious global health threat. It also called for 7 urgent priority actions that leaders must take to prepare across 5 areas: leadership, building multi-sectoral country systems, research and development, financing, and robust international coordination. They also outlined progress indicators for each urgent action. So, for instance, for institutions that must be prepared for the worst, the progress indicators included WHO and its member states developing options for standard procedures and timelines for sharing of that sequence data, specimens, and medical countermeasures for pathogens other than influenza. Okay, so in the past section, we reviewed mitigation in the pre-COVID-19 era, so you have a sense of the global and national experience in preparedness prior to the ongoing pandemic. Let's take a look now at some key strategies and tools that have emerged while dealing with this pandemic. My approach will be to share key resources to help you navigate this pandemic in real time. Back in early March is when the alarm bells started ringing in the medical literature. For instance, a team from Johns Hopkins published a viewpoint in the Journal of the American Medical Association. They emphasized the need to prepare the U.S. healthcare sector for COVID-19 given the time lag for therapeutic approaches. Recommendations included reviewing and updating preparedness plans, especially hospitals and clinics. You'll learn more about this aspect in week 8 of this course. The ability to accurately test individuals for the condition is clearly critical in all aspects of preparedness, so they call for diagnostic testing needs to be rapidly expanding, including site availability and the capacity, and clear characteristics such as predictive values of diagnostic tests. Public health actions such as early contact tracing, social distancing need to be implemented to slow the spread of the epidemic. They emphasized in particular that political and public health leaders will need to consider the potential benefit of any closures, along with their negative societal costs. So, for instance, school closures will impact single parents in the workforce. Lastly, they reinforced the need for public health leaders to clearly communicate to the public about the way they can lower the risk of infection and spread. A couple weeks later, the chair of the Global Outbreak Alert and Response Network, Goarn, and the co-chair of the Lancet Infectious Diseases Commission on Preparedness for Emerging Epidemic Threats called for all countries to immediately activate the highest level of national response management protocols to ensure the all-of-government and all-of-society approach needed to contain COVID-19 with non-pharmaceutical measures. They noted that the demand on facilities, the number of test kits, personal protective equipment, and medication stockpiles should be forecast to enable scale-up. Surveillance needs to be expanded to test all patients with atypical pneumonias for COVID-19, and COVID-19 testing needs to be added to existing surveillance systems for influenza-like illnesses and severe acute respiratory infections. Further, a wide net should be cast on contact tracing with legally enforced implementation. We'll talk more about this next week. They continued there should be a wide-reaching and possibly unpopular mobility set of restrictions, limited social interaction, and canceled gatherings. People should be strongly encouraged to stay home and work from home when possible. In addition, all countries need to continue liberal testing, proactive case detection, prompt isolation, rigorous contact tracing, and enforcement of quarantine of all contacts, irrespective of which phase of the outbreak they're in. So all this sounds really familiar to you now, right? What's happened since then? So the NPIs we discussed previously have all been recommended, are in use. In week 7, you will discuss how differing methodologies have been most effective in stemming the pandemic thus far. So what we'll focus on now is the new tools that have emerged that are helping to mitigate the pandemic. So what strategies do you think that have been employed that we haven't discussed at this point? As our global population went online to reduce transmission, the digital landscape transformed to become a key part of the COVID-19 response. There's been a steady stream of data generated during this pandemic, from the individual to the country level, generating enormous data sets. Research and provider institutions have increasingly turned to big data analytic tools to track and monitor the virus's spread and its effect on patient outcomes. Data analytics is the process of examining data sets in order to find trends and draw conclusions about the information they contain. Big data analytics is the use of advanced and analytic techniques against very large, diverse datasets that include structured, semi-structured, and unstructured data from different sources and in different sizes from terabytes to zettabytes. Data analytics enables us to track which solutions work and which don't work, to identify where the virus is currently having the biggest impact, and to deliver the right resources to the right communities at the right time. Predictive analytical tools have also played an integral part in healthcare organizations' response to and defense against the virus. Predictive analytics includes the use of data, statistical algorithms, and machine learning techniques to identify the likelihood of future outcomes based on historical data. The goal is to go beyond knowing what has happened to providing the best assessment of what will happen in the future. It's been used to map the spread of the virus, forecast disease severity and risk, and used to plan for resource demands and constraints. In September, the NIH launched a new analytics platform that contains clinical data from the electronic health records of people who were tested for the novel coronavirus or who have had related symptoms. Part of the NCATS, National COVID Cohort Collaborative Data Enclave, the centralized and secure data platform, features very powerful analytics capabilities for online discovery, visualization, and collaboration. I included a link to it so you can take a look if you're interested. The CDC also generated a guide, the link is also provided, that compares digital tools that have been deployed in various countries for contact tracing investigations and/or national surveillance. The spread of infectious disease is inherently a spatial process. John Snow's map of London's 1894 cholera outbreak was celebrated as a breakthrough of epidemiological cartography. During this pandemic, geospatial data has been a central part of the response. Geospatial is used to indicate that data has a geographic component to it, so the records in a dataset may have locational information that's tied to them, such as geographic data in the form of coordinates, an address, city, or even a zip code. GIS refers to a system where geographic information is stored in layers and integrated with geographic software programs so that spatial information can be created, stored, manipulated, analyzed, and visualized or mapped. GIS data is a form of geospatial data. Other geospatial data can originate from GPS data, satellite imagery. Incorporating geographic information, science and technology into, this is also known as GIS&T, into COVID-19 pandemic surveillance, modeling, and response has been key to understanding and controlling this disease. Applications during the pandemic have included developing spatial data infrastructures for surveillance and data sharing, incorporating mobility data into infectious disease forecasting, using geospatial technologies for digital contact tracing, we'll talk more about this next, and integrating geographic data into COVID-19 modeling. Also, this includes investigating geographic social vulnerabilities and health disparities, and communicating the status of the disease or status of facilities for return to normal operations. Locations and availability of personal protective equipment, ventilators, hospital beds, and other items can be optimized with the use of this particular approach. Using geospatial data does come with constraints such as privacy. Check out the above video from Esri, a leader in the geospatial world, in which S.D. Garrity, their Chief Medical Officer, can walk you through how different institutions, states, and countries have used GIS during the pandemic. In some countries, digital approaches have included QR codes on smartphones that control entrance into public places and monitor activity on the basis of the individual's COVID-19 health status. They report travel history, contacts, and health information such as body temperature. Some apps are directly linked to police departments, and reports may include age and gender. Contact tracing specifically identifies the individuals that have been in contact with someone who has tested positive for COVID-19. So in Bucks County, we are characterizing contact as less than 6 feet away for more than or equal to 15 minutes. This is a time and people-intensive effort. However, concerns about data security and privacy have presented roadblocks to ubiquitous public adoption of contact tracing apps. In August this year, Braithwaite et al. Noted that based on modeling studies, controlling COVID-19 requires a high population uptake of automated contact tracing apps, so from about 56 to 95%, alongside other control measures. The biggest issue, however, has been whether to send data to central health authorities. Proponents of the centralized approach, shown on the left, highlight that the data going to a centralized location helps public health officials to understand the spread of the disease. At first, the UK's NHS app was centralized, but in June they switched to a decentralized version. In decentralized approaches, shown on the right, such as the app jointly designed by Apple and Google, there's a higher level of anonymity. The data stays on users' phones. They give permission for their anonymous beacons to be transmitted. If one person becomes infected with COVID-19 and records that in the app, a server can broadcast that to everyone with the app. And an individual phone can use that information to figure out if you, for instance, have been close to that anonymous beacon of that COVID-19 patient. You can click on any of the links for a look at some of these apps, as well as for a global comparison of contact tracing apps. Data visualization has also become indispensable during this pandemic. From looking at a map from the University of Maryland showing the number of cases on the top right, to health messaging in the center image, and comparing the number of cases to other diseases on the bottom graph, we have seen information represented in all sorts of pictorial ways. Charts help us to make a quick assessment and understanding of the pandemic and to keep pace with how the situation is developing. Creating effective data visualizations that appeal to a broad audience helps us to disseminate accurate information with the right message. Stanford Associate Professor Kristen Sainini offers some basic principles for producing an effective visualization. She recommends that you consider the type of graph that you use, be sure the information is interpreted accurately based on proportion, and be wary of cluttering the screen in visualization with extraneous information. So what do you think? Is it too cluttered to have 3 animations on the right? Does it distract from the messages on the slide? So I'm including a link to her free webinar on this topic. In it, she'll introduce you to basic concepts in data visualization, including a how-to graph of different types of data, principles of effective data visualization, and how graphs can even be misleading. She'll also show you how different visual representations of the same data can convey very different messages. We can see good examples of visualization in some of the COVID-19 dashboards that have been developed, not only by public health institutions like the CDC, but also by news agencies. We'll review a couple sites. If you examine them, you'll be able to find the sources of data as well as the methods of analysis used. If you haven't visited it yet, check out the Coronavirus Resource Center, Johns Hopkins. This is one of the sites featured in the Esri video that I provided a link to a couple slides ago. On their site, you can receive a daily update, data in motion report, track trends in testing, and cases according to your region or globally. There are also multiple e-learning opportunities such as their contact tracing course. So for instance, explore this interactive on their site, the impact of opening and closing decisions by state. We'll talk more about the state level response a bit next week. During the pandemic, it also became clear that the disease was disproportionately affecting the most vulnerable and disadvantaged populations in the U.S. the hardest. Access to racial breakdowns of COVID-19 data is key to understanding how racial disparities affect the spread of the virus throughout the U.S. So take a look at this link that shows which states have released data according to race. Also on this front, the New York Times has multiple maps and trackers on their dashboard that are updated daily according to state and global breakdowns. They're also tracking the populations that have been hit the hardest, including nursing homes and long-term care facilities, jails and prisons, as well as food production facilities. There's also a vaccine tracker that gives the status of all the vaccines that have reached trials in humans, along with a selection of vaccines still being tested. Access to the web version is free. An account may be required for access in some of the app versions. So as the COVID-19 pandemic continues to unfold, with all our past experiences and new digital tools at our disposal, what does history tell us about how it might end? In the case of the 19 influenza pandemic, the virus became endemic. It was constantly maintained at a baseline level in a geographic area without any external inputs. It ended as natural infections conferred immunity on those who recovered. It also took another pandemic, H2N2 in 1957, to extinguish most of the 1918 strain. As we talked about in the previous section on SARS ended due to effective containment, isolating the sick, quarantining their contacts, and implementing social controls. Development of a vaccine was instrumental in halting the 2009 flu pandemic, and there's been a global accelerated effort on this front. Yet what happens ultimately may depend on both the evolution of the pathogen and our biological and social response to it. The end of this pandemic will likely be due to a combination of the mitigation strategies that we reviewed during this lecture. Our response, however, is still developing. In the last couple of weeks in October, the Great Barrington Declaration was made by 3 public health experts. It encourages governments to focus on protective strategies on the elderly and lift lockdown restrictions on those who are less at risk, such as the young and healthy. Doing so, they say, would be the only way to reduce the risk to the most vulnerable. I'm including a link to an opinion article on this by John Barry, a professor at Tulane University School of Public Health and Tropical Medicine, and the author of The Great Influenza, the story of the deadliest pandemic in history, another area of ethical debate. I also included a link to a BBC Interactive View that presents a historical review of the majority of the pandemics that we reviewed in the contexts of their ending. Ensure the animation is enabled at the top so you can interact with it fully. So in this lecture, we reviewed selected examples of how previous pandemics were mitigated. We talked about a variety of strategies used in the past and those that are being used during the COVID-19 pandemic. Keep in mind this is a very fluid situation, so some of this may have changed since I produced this lecture. NPIs, also known as community mitigation strategies, amongst the best ways of controlling a pandemic when vaccines are not yet available. This is a shared experience that we're all living through and experiencing together. You likely would have used some of the digital tools that have been developed, and I shared several resources that you can use to further your insight and learning. Crisis is a strong driver of creativity and innovation, and healthcare innovation can lead to new approaches to mitigate the pandemic. Much like the disinfection robot on the right, I encourage you to be part of that innovation. Here are the references used in this lecture. If you found this lecture to be interesting or interested in pandemic history, I recommend the book Epidemics in Society by Frank Snowden, a professor at Yale University. In his words, it's a book of medical history that focuses on epidemic diseases that, in his opinion, had the largest social, scientific, and cultural resonance, and strategies society deployed at various times to combat, prevent, cure, and even eradicate them. The text highlights that epidemic diseases are not random events that affect societies capriciously and without warning. To study epidemics is to understand that society's structure, its standard of living, and its political priorities. Snowden highlights that epidemic diseases have been signifiers, with the challenge being to interpret the signals. Next week, I'll address the role of the CDC, state, local, and tribal authorities in pandemic response and mitigation. If you have any questions related to this lecture, please email me. I listed my email on the title slide, or post a question on the Week 5 discussion board. So this is the end of the Week 5 lecture. Have a good week!